So today we're going to be talking about the before, during and after of some surgical emergencies. And we're both going to focus on slightly different aspects, as you can imagine from our backgrounds. I'm one of the anaesthetists at the Ralph, and then obviously Mimi working in emergency and critical care. She'll focus more on the pre and post-operative periods, and then I'll focus a bit more on the intraoperative periods. Kind of blurs a little bit because our roles obviously have so much overlap, but as we go through that will hopefully be clear. So first I wanted to just talk about what the perioperative period really is. And so perioperative refers to a process or treatment occurring or performed at or around the time of an operation. So all of the aspects that come around either side of any surgical procedure or non-surgical procedure as well. So three stages of our perioperative period: the preoperative, intraoperative and postoperative. So relatively straightforward. And then if we look further at the different phases that we might see through those periods, the preoperative involving examination, stabilization, investigations, and then pre-medication, and then this is where the lines get blurred a little bit, into our induction of anesthesia, into the intraoperative period, and then obviously recovery from anesthesia, and then into our post-operative period, further stabilization. I've put optimization there because I think it's really important that we think about optimizing our patient's care further into the recovery and post-operative periods. And then the general ongoing nursing, treatment plans and nutrition. So these are the main things that we're going to be discussing today for some of our surgical emergencies. So I've put this in here because obviously for me this is a really important thing, as I know it is for all of us. We want to be reviewing analgesia at all the different stages as we go through, so that's something that I couldn't put into the previous slide, so I've just put it all the way throughout. Okay, so I'm just going to hand over to Mimi to discuss the emergencies that we're going to be talking about.
So the main one that we're going to discuss tonight, and we feel like they are the principal one that you're most likely to see, the typical GDV, the hemo-abdomen and the polytrauma. So we're going to start with the GDV. So usually if you have this phone call like, oh, my dog has been retching and it's a German Shepherd, and in your head you should already click, oh my God, it's probably like going to be something like a GDV. And what do we usually do in terms of like understanding what could go on? I like to first of all do a proper examination. Make sure you really have a good listen and also a little like tap against the abdomen, even the caudal chest, because sometimes they're very deep chested and it can be like hidden underneath the rib. So a very good thorough examination. And what blood do I like to get for those patients? I will always try to get a baseline PCVTS. I like to get some electrolyte. Hematology biochemistry, it's not something that we'll rush for unless it's a very elderly patient, and if you can do that in-house, that's great. Otherwise, I'll take some, maybe keep it and send it later to the lab if I have any issue. Blood pressure, so be careful with your GDV because obviously you probably will have a difference between front and back leg. Think about the compression that it will create. And ECG, usually I try to get at least a trace. You can see some abnormality there. We can talk about that a bit later. Because of bleeding time, it's a very quick test that you can do on your patient, especially some of the dogs who have GDV, like your typical Weimaraner or Doberman, typical one who can have a von Willebrand factor deficiency. So that will be a quick test that you will probably need to do. Is anyone familiar with the little apparatus we use? Yeah, the little lens, and you know like the time. Anyone know how much time do they have to be considered like maybe there's an issue with the primary homeostasis? So let's say it's 2 minutes. Is that good? Is that bad? There's no wrong or right answer. Anyone? No? Well, 2 minutes would be good. More than 4 minutes, I will start to be worried. Okay. In the pre-operative phase, I suppose like if you can provide some of them oxygen, I will try to most of the time when they arrive. Sometimes they won't tolerate it. So if it stresses your patient too much, just don't do it, it's fine. But as soon as you will start sedating, I will provide some oxygen when they're a bit more calm. So there's different ways, either like flow by or mask, whichever they prefer. Sometimes even they're calm enough to put some nasal prong. It's like a little mask here. Placement of the cannula is actually pretty important, especially with GDV. So again, if you think about your big gastric dilation that compress the vena cava, often doing a venous access on the hind limb will be less effective than the front limb. Also, the front limb, you can provide medication that will reach the heart and the rest of the organ a bit faster. So it's always try to prioritize the front limb. In big dog, I often place 2 cannulae, so 1 in each front limb to be able to give more fluid to them. And just be aware that not only big dog that have GDV. I have some Dachshund having GDV. They are deep-chested, so never rule out a GDV on a small dog. In Daxi, the ear vein is a good one too, and if you really struggle, you can have the lingual vein. That's pretty good. In terms of fluid resuscitation, again, I always reach for my crystalloid first. I like my good old Hartmann. I try to avoid saline a bit more now, just because of the effect of chloride on the kidney. So bag of Hartmann, give it like 10 to 15 ml per kilo. If it's a really, really big dog and you really struggle, you can reach for your hypertonic. I usually give between 3 to 5 ml per kilo as a bolus. If you think that your pump is not going to be fast enough for a big dog who's going to need like half a liter to a liter, use a pressure bag, put the bag in it, and just pressurize the bag for the fluid to go faster. Colloids, oh my God, that's always a discussion in ECC. We love talking about colloid versus crystalloid. Again, now the flavor of the day is to try to avoid colloid, especially synthetic one. So if I have access to crystalloid or hypertonic, I would reach first before my colloids. We don't really use it anymore. Too much effect on the kidneys. Also can lead to coagulopathies a bit more, so I will try to avoid them. I'm talking about synthetic one, not the natural one like plasma. So again, that's one of the recent paper that found like there's increases incidence of coagulopathy when we use synthetic colloid. So we tend to try to avoid it even more and more. Another paper about that. So, yeah. Diagnosis, usually just based on examination, palpation. I do the little tympanic ping, like you do in cows a long time ago during your studies. You can often assess that. A right lateral radiograph would be your gold standard diagnosis. You can also have the help of the ultrasound. For me, the POCUS ultrasound has become an extension of my physical exam, so I use it all the time on those patients. So you probably will put your probe and see like just gas, just plenty of gas. And I also use it a lot when I have to decompress. We can talk to that a bit later. And also, yes, the dog has a GDV, but it could have something else too, especially older dogs. So why suddenly an older dog would have a GDV? You can think it could have a mass somewhere. Older dog can have the GDV because they have like a gastric mass, upper GI mass. So always good to check the rest of the abdomen, check the liver, do a little focus on your chest, also check if there like an obvious nodules. Check the heart, is it very hypovolemic? Does this dog also have like an underlying cardiac disease? So it's always good to practice your focus. I will try to reinforce that a lot. If you have access to ultrasound, use it as much as you can. In terms of decompression, there is a debate between gastric tube versus percutaneous. I think there's a debate again that maybe the gastric tube could be a bit better in the point of view that you won't put a needle in the stomach, but I find it really hard to do it personally. Conscious dog won't let me do it. I'll never be able to do that. I don't know if you manage to do that. I've never been able to do that on a dog and pass a tube. So I often go to the percutaneous personally with a big trocar needle, so I use a big catheter. Obviously the dog, before he wrap, has been giving some fluid, giving some methadone, is a bit more calm, and I can do that. I like to use my ultrasound just to make sure the spleen is not in the way. So that doesn't matter if you go to right or left. As soon as you see the stomach's full of gas and there's no major organ, I'm happy to put my little big catheter, big trocar. So that was an example we had, I think, early this year. It's a Weimaraner. You can see here, oh, it doesn't work. But you can see like the bloating already, like on left side of the dog. That's when we place a big, massive catheter. It's like an orange, like a big trocar. And then we just let the gas flow. So it's doing a nice little it's very satisfying noise when we manage to achieve that. Obviously, the downside with putting a trocar is like maybe the blood vessel of the stomach are compromised. So there's a risk of like creating like a laceration of the stomach, septic peritonitis. As I say, if you don't use your ultrasound, at risk of like lacerating the liver and the spleen, risk of hemo-abdomen. But those risks exist, but personally, I never experienced them, but I'm not saying that it's never going to happen. So always be mindful. Maybe if the GDV has been there for a very, very long time, I guess the chance of stomach necrosis is higher. So maybe think twice before using this technique. You can try the tube if you want. In terms of sedation and pre-operative analgesia, I reach for my methadone 0.2 mg per kg IV. I could start maybe on a fentanyl CRI if I know like the surgery could be delayed, and this dog will need to be on pain relief. Sedation, it's up to grab, but midazolam, yes, you can. I will give like a 0.3 to 0.4 on top of your methadone. Dexmedetomidine if you have ruled out any major underlying cardiac disease, most likely. Sometime if I really struggle, I will give my methadone and a little top up of like propofol or alfaxolone just to relax the dog for the dog to let me to do the percutaneous trocarization. Lidocaine infusion. So often you will see that those dogs can benefit from lidocaine infusion fairly early. They're sometimes prone to develop VPCs perioperatively, especially when the spleen has been impacted within the GDV. So often they do develop that, and it's pretty good for visceral pain. So I will often reach for lidocaine. If you have proper VPC or ventricular rhythm, so we tend to give it when it's sustained at more than 160 to 180, or when you lose your pulses, obviously, so you have like a very deficit of pulses. And then we do a CRI. Also make sure with your lidocaine, that's something that we often forgot to say a lot, is you need to make sure your potassium level is like in the high normal. If you have a low normal potassium around the 3.5 or even 3, which is kind of low, your lidocaine is not going to be as effective. So if I see that my patient has a low normal, I will try to get a high normal for the lidocaine to work a bit more. So it's always good to check that on your bloods and make sure you replenish the potassium. Now I'll give back to Andrew.
Okay, so now we're getting this closer towards our surgery for these patients. We need to provide perioperative antibiosis, and something like cefuroxime, so Zinacef, 20 milligram per kilo IV, 20 minutes prior to induction is generally what you're going to reach for. There are other antibiotic options, but generally we prefer intravenous antibiotics for our surgical period. And I always just say to give these slowly. Anything that we do give IV should be given not quickly, in a sense that we shouldn't just push things very quickly anyway, especially in our sicker patients, because it is amazing how many drugs can cause different reactions. Certainly we can see accelerated idioventricular rhythms like this one, so some ventricular complexes there, just from giving a bolus of Zinacef or coamoxiclav. And then now we're going to get on to pre-medications. So we've, in this situation, already administered an opioid and some lidocaine. We could add other things. We could add midazolam and dexmedetomidine, as we've discussed. Obviously, with dexmedetomidine, we could reduce the heart rate. We could predispose to bradyarrhythmias, but also ventricular arrhythmias as well. The lower your heart rate is, the more likely your ventricles are to take over if there is something that is likely to cause a ventricular rhythm. So if you have an inflammatory response, like in this case, your ventricles are going to be primed to go. And if your sinoatrial rate is quite low, then they're even more likely to take over. So generally, keeping the heart rate at normal, if not slightly above normal level is advised. But certainly if patients are very stressed, it's a bit of a risk-benefit analysis. Certainly a lot of those patients will benefit from just a small amount of dexmedetomidine as well. We also think about things like meropenem and paracetamol. I think these things can get forgotten quite a lot. These patients will generally be nauseous or likely to vomit post-operatively. And actually our Prevamax, our meropenem, is gas sparing or drug sparing as well. So from an anaesthetic point of view, it will reduce the amount of drugs that we need to keep these patients asleep. So very, very useful thing to give. Not going to have any negative side effects for this patient. And then paracetamol as well. There are very few patients that if you are a human is not going to get paracetamol, basically. And I think we have been scared of paracetamol for quite a long time. We know that we may see some transient increases in liver enzymes with paracetamol, but there are plenty of centres out there that are using paracetamol every 8 hours at 30 milligram per kilo IV, and that's perfectly safe for the majority of our patients. If you have significant liver or renal dysfunction, then I would reevaluate that. Yeah, certainly a lot of our patients will benefit from paracetamol. When we talk about dosing, we know that certainly in ovarian hysterectomies in dogs, that 15 milligram per kilo IV paracetamol is equivalent to carprofen in terms of post-op analgesia. So very, very useful thing to add in our multimodal approach to analgesia. Going to talk a little bit more about analgesia. So we generally consider non-pharmacological therapies, regional local anaesthesia, our non-opioid systemic analgesics, and then our systemic opioids. In terms of non-pharmacological therapies, so us decompressing the stomach in this situation is a non-pharmacological therapy that's going to make this patient a lot more comfortable. Regional and local anaesthesia, so we can do line blocks in this case, we can do intraperitoneal local anaesthesia, generally not preoperative. Obviously these are going to be things that we do a bit later on, but that's something I'm going to have in my mind. Non-opioid systemic analgesics, we're thinking obviously things like the lidocaine, the paracetamol. We can add in ketamine, etc. down the line if we need further analgesia. And as systemic opioids, in this case we've given methadone. We can give boluses of fentanyl if you have it available intraoperatively as well. Generally, when we're thinking about maintenance of anaesthesia, we want to try and have multiple drugs on board that are going to improve our anaesthetic depth and plane without having to use a whole load of volatile or injectable anaesthesia to maintain our patients. So it's going to really help us to not have to turn our vaporizer dial up and down quite so much. So we're going to talk about the induction phase now. So the co-induction is a tool or something that we can do that is very, very useful to make things a little bit safer for our very sick patients. So the aim here being that we give drugs with our induction agent, so with our propofol, with our alfaxolone, and it reduces overall the amount of induction agent that we're going to give. So we can use midazolam, we can use ketamine, we can use fentanyl, we can use lidocaine as boluses at the time of induction. Now, when we do this, especially if our patients aren't very sick or sedate, we would always give a small bit of propofol first. What we don't want to do is give a whole load of midazolam and ketamine and have a patient who is bouncing off the walls. So we want to give normally 1 milligram per kilo of our propofol or alfaxolone, and then we would give a bolus of midazolam plus or minus any of these others, and then we would wait and see if we needed more induction agent to give to effect. Generally, after a decent bolus of midazolam, for example, 0.4 milligram per kilo combined with your propofol, or maybe a 2 milligram, 3 milligram per kilo bolus of ketamine, maybe a 4 or 5 microgram per kilo bolus of fentanyl, you're going to really reduce the amount of propofol that you need. Normally 1 mg per kg is more than enough. So what's next? We've induced our patient, we're going to prioritise monitoring. It's always good to get into the habit of just putting a finger on some pulses, feel for femoral pulse at this point, just to check that your patient is still alive. It's one of the highest risk periods, and I think we underestimate how quickly things can go wrong. These patients are going to be high risk for regurg as well, so having a smooth induction and an appropriate depth when you come to intubating is really important. So we want them to be at a decent plane of anaesthesia before we try sticking the tube in. If they cough and gag, they're going to increase their intra-abdominal pressure and they're going to be more likely to regurgitate at this point. Keep the head elevated, inflate the ET tube cuff before lowering the head. Obviously have suction available if you have things like that available to you. And it might be best at this point to pass a gastric tube just to empty the stomach before you start changing the recumbency of the patient, etc., to reduce the risk of further reflux or regurgitation. Monitoring, obviously really key, so we're going to get all of our monitoring on our patient, whatever you have available to you. Obviously I've listed the things that we would normally place for monitoring on our patients, but again, really does depend on what you have available to you. The key here is get the monitoring on and monitor your patient for at least a few minutes before you start changing recumbency. A lot of these very sick patients, they may be behind on fluid, they may have a big distended abdominal viscera in this case. And if you change their recumbency very quickly, they're likely to have significant decrease in their venous return to the heart, maybe vagal episodes as well, and they can become very bradycardic and very unstable very quickly. So make sure your patient is stable. If they're severely hypotensive tachycardic, maybe they need a fluid bolus after induction just to get them stabilized. Maybe you want to spend a bit of time just decreasing your volatile, maybe getting some other drugs on board before you start changing the recumbency. We're going to continue fluids, so 3 to 5 ml per kilo per hour intravenously, plus bolusing as required. Generally, the trend is now towards lower and lower fluid rates intraoperatively. Still, for the sicker patients like this, where I think that they're likely to be behind on fluids, I will tend to lean towards the higher rates. We don't have good evidence necessarily either way, but the recommendations are slowly creeping lower and lower in terms of the amount of fluid that we give to our patients intraoperatively. Generally, if you're using lower fluid rates and you need more, boluses is a great way to do that anyway. Often it's a lot more targeted when we're thinking about the amount of fluid that we're giving to our patients. And then any additional analgesia, so boluses of all of the drugs we've discussed already, and infusions as well. So it's not always that practical to give infusions. You may not have a syringe driver, for example, where you're working, but if you look at the website here, vasg.org, they have a lot of different recipes essentially for making up different bags of drugs, and they'll give you all of the volumes, etc. you need to put into a bag and the rates that you need to run them at. So very, very useful to be able to do that in practice. Generally, I would say I've put pulse quality in here because it's really important. So we often do listen to the thorax with a stethoscope, but really it's not the most useful technique. You can hear a heartbeat and not have pulses. So for me, if we can get really practiced at assessing pulse quality, it's really, really useful, especially to guide things like fluid responsiveness as well. So, as I've said already, reducing our volatile anaesthetic based on assessment of anaesthetic plane is really important, obviously all the time, to be able to tweak out isoflurane or sevoflurane, whatever we're using, as low as we can to maintain normal blood pressures. Repeating antibiosis, so normally every 90 to 120 minutes. And then blood pressure management. So again, we're maintaining a normal heart rate, if not slightly higher than normal. Obviously for patients that have a pathology like this, they're likely to have a much, much higher heart rate than normal. So we're not using that as their baseline. We're using what we would expect their normal resting heart rate to be as our guide. So, you know, if your GDV's got a heart rate of 40, that's probably inappropriate. So actually pushing it up a little bit to 80 is very reasonable. We can use atropine for that. We can use glycopyrrolate for that. There's lots of options. We can even use terbutaline if we want to discuss that as well. Probably not in cases like this because you can get some vasodilation, but there are plenty of drugs that we can use to increase our heart rate. And then vasoactive drugs, so other things that we might consider like ephedrine, noradrenaline, and then we're kind of getting into a whole nother lecture, so I won't go into much more detail on that. Again, reevaluating our analgesia, so no non-pharmacological therapies at this point, but this is where we can do our intraperitoneal local anaesthesia. So we're literally just putting 2 milligram per kilo of local anaesthetic into the abdomen before we close, and we're shaking it around a little bit and then closing them up. And then incisional line blocks as well as an alternative, both really, really good options. Again, we can add lidocaine, ketamine. We've got paracetamol on board, hopefully by this point, and then topping up our methadone as required. The dose range for methadone is huge. In the formulary, it goes up to 1 milligram per kilo. I wouldn't give that much. Generally, I don't give over 0.5 milligram per kilo of methadone because if you want to see opioid side effects, give more methadone above 0.5 and you will see them. So we tend to avoid that and try and think a bit more multimodal, but certainly fentanyl, if you have it as well, small boluses, 2, 3, 4 microgram per kilo are really, really safe and will make a really big difference to being able to reduce the amount of volatile that you're using as well. So for the recovery period, again, does my patient have adequate analgesia on board? You don't want to have a horrible recovery where your methadone's lapsed, for example. If you haven't had to top up other drugs during the procedure, it's sometimes easy to forget that that methadone might have lapsed from when you first administered it at admit. Is the bladder full? Does it need expressing? For all of our procedures, all of our surgeries, we really should be thinking, do we need to empty the bladder? It's a huge risk factor for having a really awful recovery if you've got a full bladder. So yeah, wherever you can, empty them. You might consider placing a urinary catheter in some of your sicker patients. If you're continuing ongoing antibiosis, you might think twice about that, given the risk of multi-drug resistant infections, but generally if you want to measure your fluid ins and outs, they can be very, very useful. And then does my patient need a feeding tube? Again, nutrition, really key for a lot of our patients for recovering. If it's an acute GDV and your patient has no other comorbidities, chances are they may eat relatively quickly, but certainly if they are much older or have other comorbidities that may reduce the chances of them eating post-op, then think about your feeding tubes. And is the patient anxious? Do I need to, have station on board? Hopefully you've got your patient to a pretty stable place by this point, so you may be able to give a small amount of dexmedetomidine on recovery, for example, very safely. You can also give trazodone rectally as well under GA. Normally if you give it around about 30 to 40 minutes before you wake the patient up, that will work very nicely. We use the same oral dose, it's absorbed very, very well. We normally just open the capsules, pop it in a syringe with some saline and get a urinary catheter or a large intravenous catheter and put that rectally, and it works very, very well for our very, very stressed patients.
So now Andrew has brought me back my very sick patient that has stabilized very well before. So what do I want to monitor? So cardiovascular is prime. So we often have them on the ECG when they recover, just to make sure they're not developing any type of arrhythmia. The most common one would be like some AVR or VPCs, as said earlier. Hopefully by this time you probably will have your lidocaine on board already. If not, you could start considering starting it. Or you can also, as I said earlier, check your potassium to make sure everything is correct in terms of electrolyte balance. Urine output, yes. It's not something that we'll prioritize on all the cases, but definitely the sicker one, the one who have like comorbidity, 100% I would like to have an in and out. They tend to sometimes be given a lot of fluid pre-op, sometimes a lot of fluid intra-op. We need to make sure they eliminate all of that. And it's a good way to see if they start developing like an AKI, for example, from the previous shock. You can always collect some urine and check if there's like protein or glucose. That will be also like one of your first marker of like a kidney injury. Pain scoring, we assess them if we have any concern and we can't get on top of the pain. I often ask my friend from anesthesia to reassess the patient, make sure we are pretty good with our multimodal management. Food and water intake, I don't expect them to eat straight away post-op, but if they don't eat by the following day by themselves, I will either use the feeding tube that they have in place already or place one. So it's always better if you put them one day under anesthesia at the end of surgery, because nothing worse than like a dog that doesn't like to be touched and you try to put something in the nose. So it's easier to remove it than place one. So I will suggest, like for every of your patient you have any doubt that they're not gonna eat, to place one on recovery. Nausea, does my dog look like he wants to vomit or is nauseous? Should I continue the maropitant? Should I try to give other drugs such as ondansetron, which is pretty good for nausea? Should I assess for ileus? Is the guts are moving? Post-general anesthesia, often you have ileus. Should I start my metoclopramide? Should I consider cisopride? Is my stomach actually full? Should I like empty it with the feeding tube? Ongoing antibiosis, usually I guess for GDVs, unless there will be some gastric resection or sign of leakage in the abdomen, I will not tend to continue my antibiosis. I think the cefuroximab giving intra should be enough, but there's any doubt of leakage into the abdominal cavity, then you can consider continuing it. I usually switch to coamoxiclav that I give IV, 20 milligram per kilogram IV. And continue if there's any sign. The duration of it, that would be like a hard question to answer, but I will say at least 5 days to a week of antibiotic if there has been some contamination. So that's a little flow chart that's pretty useful, like is my patient tachycardic and hypotensive, that help you to know what should I do. So is it tachycardic plus hypotensive? Yes. So often the answer with that would be try to administer a fluid bolus. Is it not? Is it just tachycardic and normotensive? Then you could try another fluid bolus. If it doesn't resolve, you need to look for another cause of the tachycardia. Is my patient painful? Is he stressed? Is he nauseous? Does he have a full bladder? Is his stomach full and I need to empty it? Otherwise, so the patient is completely normal, great. Is the patient eating and drinking? Even better. Do I need to continue the fluid? Probably not. And so if everything is fine, I will usually like stop the fluid, leave the dog drink and eat as he wants. If he's normotensive and not tachycardic, but he's not drinking and eating, just continue to supplement fluid at like normal rate at 2 to 3 ml per kilo per hour. Remember, younger dog need higher fluid rate. Usually like puppies and very young dog need sometimes up to 8 ml per kilo per hour. That's a normal rate. But adult dog should be like 2 to 3 ml per kilo per hour. Obviously, make sure that your patient doesn't have any underlying cardiac disease. It could be normotensive and having a normal heart rate, but have underlying cardiac disease. You might have to be a bit more careful with your fluid. So again, the little table there. So for me, like in non-pharmacological therapy would be, is the patient able to walk and urinate? Is he able to move? Because sometimes they can't move and they get pressure sore. We need to think about mobilization. Is the stomach full and bloated and painful? Do I need to decompress that? We don't really do regional or local anesthesia in ECC for those cases. Non-opioid systemic analgesic, so probably the lidocaine for me, the paracetamol I would continue. And systemic opioid, do I need to increase them? Do I need to add something else? Always be mindful with your opioids that post-surgery, they will prolong potentially the ileus. So if the patient is stable, they don't need them, try to wean them as soon as possible. That will really help with your gastric emptying. And the question, what about the NSAID? So being ECC criticalist, I don't like NSAID. I really don't. But they are great, I guess, in the longer term, once the patient has fully recovered and then I'm happy with his kidney function. But I will say in a period where the blood pressure is not the greatest, or even before the surgery, when they're completely hypovolemic and in shock, I would certainly not use non-steroidal. It could further damage the kidney. We can discuss that later, like after, if you want to know. But I will try to avoid them unless, like, the dog goes home, is completely fine, and we want to provide some further analgesia. But probably not in this, like, perioperative period. And also, especially if they're not eating well, think about your gastric ulceration and all of that. So I will try to avoid it. Personally. Again, Prevomax, do we need to continue? Maropitant, probably. It does help a lot with the vomiting and also provide a little bit of pain relief, so I will consider that if the patient have any sign of vomiting. Ondansetron, I do like this drug a lot. Have it IV. The oral dose, unfortunately, the bioavailability is a bit suboptimal, so they're not very well absorbed. So intravenous is always better. I find it sometimes superior to maropitant when the patient is purely nauseous and not actively vomiting. Or you can try, if your Prevomax is not working, to add ondansetron on top of it. I usually use like 0.5 mg per kg IV, up to 3 times daily, but twice should be enough. But remember, like the oral dose always not very well absorbed and doesn't work very well, unfortunately. Metoclopramide, yes. Again, often this patient post-op will develop ileus, so I will start my metoclopramide. I used to start usually around 2 mg per kg per day. It's always been told that you can't go higher than 2 mg per kg per day, but it's fairly safe to go higher up to like 4 to 5. If you have to go more than that and the ileus is still present, you probably will need to think about adding another prokinetic, such as like cisapride and maybe erythromycin. The thing with metoclopramide, be a bit more careful in your feline patient. Could create more extra perimeidal sign, so some neurological sign. But before reaching to all those prokinetic, I think, do I need that much opioid in my patient? And also make them walk a lot can really help too. And the next surgical emergency will be our good friend, the hemo-abdomen. So what do I need as an information? So first of all, I would think a PCV and a total solid will be pretty useful. to see is the patient still coping and his PCV is still pretty high, or most of his blood is actually in the abdominal cavity. ECG, yes, always, if you have access to it, I will put it on. Blood pressure, definitely. In this one, front leg or back leg are not that picky compared to the GDV. I will definitely try to get a blood gas if we can get some electrolyte. Biochem, hematology, if you can run them, great. If you can't, submit them externally. I suppose with your bleeding patient, you have to think, is my liver is affected? So it's always good to have a baseline regarding your liver enzyme. And if you can obviously do platelet counts in-house. So I suppose some of them will be like in the low normals, probably because the patient has been bleeding, so you will have some sort of consumptive thrombocytopenia. But I guess if you have really no platelets, it's probably going to be a bit challenging to then send this patient to surgery. I would say if your patient had at least between let's say more than 40, let's say 50,000, that would be fairly safe to go towards surgery, but less than that, the risk of bleeding are way, way too high, and they're probably going to create more harm by going into surgery. Coags, if you can have access to PT, PTT in-house, just to rule out, is it truly a bleeding mass, or is it like a rodenticide poisoning, or any type of like vitamin K deficiency, or things like that? Like, do those patients need to be cut straight away? I often found that I don't need to send my hemo-abdomen patients straight away. And I definitely need to rule out any thrombocytopenia, thrombocytopathia, and rodenticide poisoning before being sure that I can send them. Also, anaphylaxis can cause hemo-abdomen, just to say. In terms of diagnostic, again, little POCUS, very, very useful. So we can identify, is there only free fluid in the abdomen, or do I have also like in the chest, in the pericardium? I guess if you have like, bicavitary or tricavitary effusion and they're all like hemorrhagic, I would think that the issue with the platelet homeostasis is pretty high up. If it's just one cavity, I would definitely try to very pay attention, is there like a mass, an obvious mass anywhere? Also, the thoracic POCUS is very useful, again, to is there a mass, is there another effusion? How empty is my heart? So do I need to aggressively resuscitate this patient? Always think like if you see a mass in the abdomen, try to take some chest radiograph to rule out metastasis, especially with our German Shepherd or other type of breed which are more likely to have, I forgot the word for the cancer, very simple cancer that they all get, the German Shepherd. Thank you, oh my God, I couldn't get it. So hemangiosarcoma, definitely. If you're really good with your thoracic POCUS and look at the heart, sometimes you can see a right atrial mass. So maybe it's like those information are good to feed back to the carer, like, well, listen, your dog have an abdominal mass, but also have bleeding in the chest. There's a suspicious mass in the heart. Do you still want to go to surgery? I think that's a good question to ask. Oxygen supplementation, yeah, definitely. Those patients have often low level of red blood cell, so try to maximize the oxygen carrying capacity of those little red blood cells would be optimal. IV cannula placement, if you can prioritize the cephalic, it's always better. As I say, it's going faster. Also, if there's a large abdominal mass, again, it will create some compression of the vena cava, so cephalic better. But if you don't have any other access, I think saphenous is completely fine. In terms of fluid therapy to stabilize those patients, again, when I'm sure that I rule out something obviously cardiac, and I'm sure there's no other cardiac disease, and the heart look empty, I would try to reach for my little friend, the crystalloid, so I use the Hartmann. If the PCV of the patient is very low, I will try to organize some blood, but usually I'll stabilize first with the Hartmann, time for someone to get the blood ready. Obviously, if you give just packed red blood cell, you might also have to give some plasma, because what has been lost in the abdomen is whole blood, not just red blood cell. And also, if you think there's like some coagulopathy, plasma will be definitely needed. Plasma can take some time to defrost, so again, you can start stabilizing with just some Hartmann. Just be careful with your initial stabilization not to give like a full, like what we call like a shock bolus of 80 ml per kilo, because then it won't leave you much space for your blood. Just try to achieve a level where the patient is a bit more stable and leave some space for the blood and the perioperative, because they are colloid, they will expand your vasculature and could push your patient to failure, so always be careful. A little tip with colloids and like natural colloid and perioperative blood cell, if you have a very small patient and you really worry to overload them, especially like some cats, for example, you can always split the unit, so you take one syringe of 10 ml and you give it very slowly over 4 hours, as long as the rest of the blood is in the fridge. As long as the small amount that you're giving is within 4 hours, you can give in longer, unless your patient is actively dying, so in that case you give a bolus, obviously. So we try to resuscitate either with Hartmann, then we can reach for blood. Vasopressor, be careful with that just in the initial phase, because if they're really hypovolemic and then you give some pressure, you would then like close those little blood vessels even more. So I will make sure my patient is adequately resuscitated first. If you suspect any rodenticide poisoning, I will primarily aim for my plasma and supplement some vitamin K. If you have some issue with your platelet function and you're concerned about bleeding because of that, you can reach for your tranexamic acid that will like inhibit your fibrinolysis. The belly bandage, yes, that's something you can consider. I don't routinely do it, but in some patients it did have helped a bit to like compress a little bit and stop the bleeding. I usually give my patient tranexamic acid. I stabilize them with either fluid or blood, and I just check all the coags and I sit tight, and hopefully I can wait for surgeon to come. With your tranexamic acid, always think about giving a little bit of maropitant. It tends to make them very vomity and nauseous, so I tend to give maropitant at the same time I give my tranexamic acid. And then we call anesthesia.
So yeah, hopefully at this point I've got a patient that is a little bit more fluid resuscitated. Hopefully their blood pressure isn't sky high though. You know, the aim is not to return this patient to have a normal awake blood pressure really, because what we don't want is all of the things that we're putting into the dog just coming straight back out, whatever's bleeding in the abdomen. So for me, I'm very happy to have a patient who's got kind of a middling mean or systolic blood pressure. So I'm happy if the systolic is sat around 100 millimeters of mercury, or if my mean blood pressure is sat around 60 to 80, I'm very happy with that. But then I need to consider how I'm going to anaesthetize this patient again, because we don't want to then suddenly cause a whole load of vasodilation if we're not fully restoring the intravascular volume for this patient. In the human world, they have moved towards a combination of pressors, blood products and crystalloids when it comes to resuscitating these patients. And there's been a significant improvement in outcome for massive hemorrhage associated with trauma when it comes to finding a balance of those things, targeting slightly lower blood pressures, so lower normals. So for us, we need to think about whether we're going to pre-medicate the patient at this point. I probably wouldn't. Again, this is where we think about other options. So again, we've already discussed meropitant. Would I give paracetamol to this patient? Generally, if I'm concerned about liver perfusion, I wouldn't necessarily reach for paracetamol at this point. But certainly when we've got source control, then I'm very happy to get paracetamol on board once I'm able to fully resuscitate that patient. And that patient is going to stay resuscitated essentially, hopefully, because we've got control of the bleeding. So at this stage, there's no non-pharmacological therapies to consider, no local region at this point. Any non-systemic, non-opioid systemic analgesics, probably not. We could give methadone at this point if we wanted. Again, come back to the co-induction. A lot of these things that we'll discuss are quite similar for our emergency patients. So you'll see us talking about co-induction anaesthesis, we love it. Essentially, our propofol, we're going to give our 1 milligram per kilo, follow it with a nice concoction of different drugs, and then give more propofol to effect if needed. The more drugs you use at lower doses, ultimately you just spread your risk. The same comes into play when you're talking about giving IM pre-meds to patients that may have comorbidities and you want to use a safe protocol. Use lots of drugs, reduce the risk associated with each, but use the combined sedative or in this case anaesthetic effect of each. prioritise your monitoring again. Again, if you've got a big belly full of blood, you don't necessarily want to change the recumbency of the patient very quickly. Recipe for disaster. And again, we've talked about thoracic radiographs. Now's probably the time that we're going to do that once our patient is asleep. Just going to talk about two quick devices. These are really, really simple things. This is a pressure gauge. You can put it in your breathing system. If you are using your breathing system to provide positive pressure breath, so you can inflate your ET tube cuff, for example, it would be really useful to have one of these so that we're not overinflating. It's very, very easy to overinflate the patient's lungs or provide higher pressures than we intend to. And certainly in a patient that doesn't have a normal intravascular volume, decreasing the venous return even more by putting a whole load of pressure in the chest is not ideal. So these devices are £16 from Vet Direct. I would recommend them for anybody that is also doing IPPV under anaesthesia, for example, just so you know that you are delivering appropriate pressures. So yeah, monitoring, same again really. We're going to use whatever's available to us, and then we're going to continue our fluid therapy. Again, we've talked about the different options that we have in terms of what fluid therapy you use. Generally, at this stage, until the patient is open, I will tend to lean more towards the crystalloids, but as soon as the abdomen is open and we're getting control of the bleed, then I'll definitely move more towards the red cells. I'm trying to essentially preserve what we've got available in terms of our red cells and plasma, but I can do that because I can also use pressors and things like that to bring the blood pressure up to a reasonable level so that we're not causing more trouble for our person operating. Again, already talked about what they're doing in the human world, but certainly with major traumatic hemorrhage, odds of survival when using this combined frozen plasma and, plasma and packed red blood cell product is 1.5 times higher who receive the combination surviving 24 hours. Certainly, plasma is an easy thing to keep in. You may not have access to blood, but you can keep fresh frozen plasma in the freezer for up to a year, and then it just becomes stored plasma or fresh plasma after a year, but will still have some colloid effect and can be very useful, even though it may not replace coagulation factors. We can talk about autotransfusion as well. So, I mean, if you're very lucky, you might have a cell saver device which takes the blood out with a suction and then filters it all, removes all the nasty white blood cells and cancer cells that might be in there, and then you can give it back to your patient. But obviously, most of us do not have access to those kind of things. But what you can do is just take the blood out of the abdomen with syringes. Generally, that blood is not likely to clot, but you can also add some anticoagulant as well to it. It depends on whether the patient is actively bleeding or if that blood's been sat there for a period of time. If it's been actively bleeding, then I would definitely add some anticoagulant. I would just, if you can get access to them and get them in, these are leukocyte reduction filters. Essentially, if you run the blood through those filters, then it's going to reduce the amount of, or remove the leukocytes from the blood, which may be inflammatory and not something you want to necessarily put back in, and also remove some of the any cancerous cells that may be floating around if we've got a bleeding mass. So what I would always say is, even if you're not sure if you're going to use it, just take the blood. It's easier to have it and then have it ready and waiting next to the patient in case you do need it, especially for those more unstable patients. So preoperative antibiotics, again, same as before, and again, just administer them slowly. These cases are really likely to have arrhythmias again, so we want to be very careful. Again, boluses of additional analgesia, our fentanyl, ketamine, lidocaine, etc., and then running any infusions that we may be able to run. Again, very, very similar themes, but we're reducing our volatile anaesthetic based on assessment of anaesthetic plane constantly, and all of these other drugs that we add in are going to be able to help us to do that. All of this is going to make blood pressure management so much easier, but again, maintaining normal heart rates is really important. And again, if you have the availability of vasoactive drugs, again, whole other lecture, but they can be very useful as well, certainly to reduce the amount of fluids that you need to give these patients. Again, we're going to review our analgesia. So this is again where we're looking at intraperitoneal local anaesthesia before we close the abdomen, or incisional line blocks. And then again, lidocaine, ketamine, paracetamol, methadone or fentanyl, or both. And so for our recovery period, again, have we got appropriate analgesia on board, emptying the bladder, urinary catheters if you feel that that's necessary. Do they need a feeding tube? And again, do we need some sedation on board? Hopefully, again, our patient is more stable at this point, so could tolerate low doses of sedation for our dogs that we think are likely to have very stressful recoveries. Rectal trazodone, again, very nice option.
So they brought us for a little dog that was in surgery. I always like to have them on like a monitor for at least the first hours and make sure everything is fine. Urine output, if they have a urinary catheter, otherwise you can quantify it. Again, those patients has been markedly hypotensive or potentially like pre-op, so risk of AKI is high, so you definitely want to measure that and tailor the fluid therapy accordingly. Pain scoring, again, that's something we do regularly every time we check the patient and adjust the drug accordingly. Food, water intake as usual. Nausea, do I need to escalate my anti-nausea medication? Do I need to add maropitanol and etc.? Is there any ileus? I just wanted to mention something that I didn't mention earlier with hemo-abdomen. When I collect a sample to see what type of fluid, I always look at as a smear in-house just to make sure there's not a bacterial contamination. It could be just blood, but sometimes it could be a ruptured liver abscess and they are actually septic and you need to start your antibiotic earlier in those patients. Just I forgot to mention that earlier. So ongoing antibiotics will be if there is like a sign it was a ruptured bleeding abscess. Yeah, it does happen. Again, the same little flow chart as before. So just to assess, do I need more fluid in my patient, they're tachycardic and hypotensive, or are they just tachycardic and they need more pain, or do they need to pee, or is there anything I can do to make them more comfortable? Do I actually need the fluid? So often those patients will be given a lot of fluid pre and intra-op. They are at much risk of like being overloaded. So you try to de-escalate your fluid therapy fairly quickly. It's better to be a little bit under than overhydrated or overloaded because it will really impact your kidney a lot. Start having like renal edema. They will further impair the kidney function. So really important to think about de-escalation of fluid. There's like the ROSE protocol, you can Google that, ROSE protocol for fluid, so the resuscitation phase, optimization, so really important to like de-escalate. Again, post-operative analgesia, so is there anything I can do to make my patient more comfortable if I think he's painful? Is the stomach bloated? Is he uncomfortable? Is actually moving? Sometimes all the patient, they need to be moved, they have some proms, so some passive range of motion. Do I have enough analgesia on board? Blocks, I don't usually do blocks, but if I really need to and I think my patient is painful, I call Andrew and he can do a block. Non-opioid systemic analgesic, so we often have the lidocaine and the ketamine. Do I will need NSAID? Again, I probably won't reach for my NSAID. You know me, I don't like it unless the patient is doing very, very well and is eating, but usually in the perioperative phase, I will not. And systemic opioid, yes, definitely. Do they need to be so high? If I have ileus, always try to reassess the use of it and the dose of it. So again, what about NSAID? I guess my answer will be probably not at this stage for the hemo-abdomen. The last one we'll talk about is the typical polytrauma case. This one we're going to try to be a bit more interactive and asking some questions, so be ready. Cool. So this is a typical dog that you'll have, like polytrauma, look like it's been run over by a car. And I guess my advice with those ones is don't focus to the obvious. So often you'll see like a broken leg with the bone sticking out, yes, but what's happening inside? Is there any other pathology? So great to localize that. Sometimes you will probably need to clip and shave all those fur to try to see more, but don't only focus on like the obvious broken limb. Do a full assessment of those patients. So on this one, I know you can see where he has a flared chest. Yeah, it's pretty cool. I like flared chest. But again, that could mean like there's other trauma inside. So he could have like a fracture rib, could have a laceration, could like have a bleeding into the chest, like, yeah. So typical TBI, a typical cat with polytrauma, you think about TBI. Other consideration you can have, cardiac contusion, lung contusion, flared chest, any type of tracheal rupture or upper airway rupture, diaphragmatic rupture, any abdominal wall rupture. Is the bladder intact? How bad is my spine, my pelvis? So it's really a full assessment of the patient. So this cat, I don't know if you can see, but he has a bit of like a goiter situation going on. He actually have like a tracheal little rupture. There was like air coming in and out. That was actually also pretty cool. Again, do I need to focus just on that? Probably not. Probably the least of is worried right now. Oh, I know, he's cute. So quick fire. You have a polytrauma dog or cat coming. Should I give this patient NSAID? Yeah, no. No. But like those patients are in shock already. The kidney are suffering. All they want is to have more blood coming. If you give you NSAID, that will like further like constrict all the blood supply to the kidney and probably lead to AKI. So no. Should I provide antibiosis? Someone say meh? Any more convincing opinion in the audience?
Take a swab, and if the wound is open, then yes.
Yeah, so if there's a wound and it's open, yeah. I would say if there's any like major wound trauma or like open skin, I will probably start antibiotics. So I will clean the wound, take a swab, start it. If they come back negative, awesome. If there's any sign of like open fracture, obviously antibiotics straight away. If it's just a very mild abrasion, probably not, but it will really depend on the size and the degree of your wound. Usually, I will start like any even dog bite, when it's a tiny puncture, start antibiotic. They go very deep, they're really dirty, and sometimes you think it's nothing, but actually it has reached the abdominal cavity, so yeah.
So what fluid resuscitation should I use for these patients? Yeah, crystalloids are going to work perfectly fine, yeah. Again, it's just about paying close attention to their cardiovascular status. A lot of these patients will be more unstable than you realise sometimes. Certainly, if they've got pelvic fractures. We've had multiple complex pelvic fractures that just continue to bleed. And because you can't see it, obviously, it's really can throw you. But yeah, certainly they can require quite a significant amount of fluid. So what might I consider for a patient with lung contusions? Is there any specific way you might approach these cases? This is a bit more a difficult question. So certainly managing ventilation can be quite challenging in these patients. Certainly we need to try and identify if these patients do have lung contusions to start with. So do you want to just pop to the next one? So there's different modalities for doing this. You can use your POCUS for this as well, your ultrasound. So that's the image on the left. You might see a shred sign like we can see there. In the middle, obviously, our X-ray, and then right CT. Obviously you can see quite nicely on your CT, but not necessarily going to have that available. So certainly there may be significant impact on the patient's ability to ventilate, and if you're going to anaesthetise these patients, they're going to probably require ventilation if they have severe enough contusions, but that in itself can be very, very challenging. Again, whole nother lecture, but certainly if you have these pressure valves as well, it can make it a lot safer to provide IPPV to these patients.
And just keep in mind, like often pulmonary contusion, they will tend to get worse, at least for 24 to 48 hours. So often the polytrauma patient, I tend not to send them to surgery straight away. I let them like recover, especially the TBI one. They're very sensitive to going on the GA, and like the brain might sometimes not support it. So I tend to leave them 24, 48 hours to make sure everything is fine, check the pulmonary function, make sure they're a bit brighter, and then I will start further investigation. You don't always need to rush those polytrauma. You can actually wait to stabilize. That's another example of pulmonary contusion. Again, POCUS, great. Practice your POCUS. The valve.
Yep, another pressure valve. If you didn't see it before, yeah. £16 Vet Direct, great. Yeah. I don't work for Vet Direct, by the way.
Anything else for you?
Oh, yes, and yeah, so again, if we're inflating ET tube cuffs, quite a lot of the time we would have a listen as somebody provides a positive pressure breath, and then we would inflate the cuff until you can stop hearing the leak. That is as sensitive as just palpating the little pilot balloon, to be honest, in terms of accuracy of filling the cuffs to the right pressure. But you can get these are 30 quid, you can get these from Burton's, again, don't work for Burton's either, but you can use these to assess the pressure in your cuff. So yeah, very cheap and easy to use, especially for patients with lung contusions. We really don't want to be giving them big breaths to be able to assess the ET tube cuff. So what might I consider for a patient with cardiac contusions? What would be our considerations for that?
You want an ECG of?
Yeah, definitely. Yep, so we certainly might see ECG changes, which we're going to talk a little bit about more on the next slide. There you go. So yeah, we can see with this one that we've got PQRS negative T, but essentially here you've got ST segment depression, and this can be consistent with myocardial hypoxia, basically. So you may have contusion, you may have a myocardial infarction, or just general systemic hypoxemia that could result in this. So yeah, something to watch out for. Most of our ECG monitors are not particularly diagnostic, so it really does depend on where the patient's limbs are, and assuming that you have the ECG pads and cables, etc., connected to the right limbs. But yeah, if you do see a change in your rhythm, or if you do see such a profound ST depression like this, then yeah, you certainly want to be thinking about, does my patient have a cardiac pathology? The main thing with these guys is maintaining perfusion, right? So we want to oxygen supplement them as much as we can. We want to make sure that their blood pressure is as normal as possible, and that their intravascular volume is as normal as possible, so that we can make sure that perfusion to the heart is great. We don't want to make the heart do too much, so we don't want to have a tachycardic patient. So making sure that they're not tachycardic, again, also not bradycardic as well, because we just don't want to force the heart to work too hard. We wouldn't necessarily give drug like alpha-2s, because we don't want to constrict our patient and make our heart have to work really hard pushing against the constricted periphery. So that also may reduce our coronary blood flow as well. So yeah, generally I'd think about how we're going to just maintain perfusion without having to make the heart work very hard.
And I guess you develop like ventricular arrhythmia, reach your lidocaine earlier than in other type of cases. Lidocaine work wonders with hypoxemic heart, just because the way the lidocaine will bind to the sodium channel in hypoxic area of the heart. So maybe it's one where I will use my lidocaine a bit when I start seeing VPCs and I'm very worried about cardiac contusion, because those parts of the heart are hypoxic. Why pelvic fracture could be very problematic? So why should I be very worried about them?
Bowel laceration?
Yeah, definitely. Good one. Anything else?
Yeah, bleeding. Yeah. Ability to urinate, yeah.
And I guess for us, so all of that are completely valid, but also, the risk of bleeding, we tend to underestimate how much pelvic fracture can lead to bleeding, and often they will develop like swelling, and we're like, oh my God, my patient's actually anemic. It's probably all the blood that from the pelvic fracture is going to the tissues. It's not unusual to have those patients coming initially in the first hour, PCV is fine, and you recheck the following day is have like dropped by like a quarter to a third. So really be mindful and checking your PCV regularly on those patients. Then probably will need some sort of a transfusion pre-op just to be more stable for the GA.
Yeah, and certainly with the amount of information that you can get as well, you can get quite a profound systemic inflammatory response. So these patients start to behave as if they were septic because they have huge inflammatory mediator release. Often because they're painful and dealing with that information for a long period of time, they exhaust their stress response as well. So getting on top of their analgesia early is really, really important, because you don't want them to run out of cortisol and catecholamines, because that's essentially what's going to keep them alive later on.
So what else can I do to maximize patient outcome in those polytrauma cases?
So we're talking a bit more holistically here. So beyond our surgical management, pharmacological management, what else can we do with these patients?
No takers for this one?
It's a very broad one, to be fair. So here we're talking about keeping our patients moving, essentially. So a lot of our patients will spend 24 hours or 23 hours in a kennel. And it's very often that you'll find specific times that they're taken out for toileting, et cetera, or just if they need to toilet. And they may have a urinary catheter in place, and actually they're not going to be out for walks anyway to toilet. So it's really important to keep these patients moving. Certainly in terms of the inflammatory response as well, it can be really useful for them to not just be sat there lying, especially in sort of lung recumbency. So we do generally try and get patients like this moving as soon as we can. It's very, very difficult to achieve, but certainly if they're well analgesed, then we can get them moving.
Yeah. And I guess also going back to the typical cat with TBI, make sure you have the whole body raised, not just the head, and provide all those like care for those TBI one. That's another thing that you can do just by putting a mattress and a towel roll underneath, like 20-degree angle, but really not just the head, the whole body.
Certainly if you've got lung contusions as well, or if you've got aspiration pneumonia or anything like that, with these very sick cases, movement is really, really important. It seems about counterintuitive because we don't want our patients to overexert themselves and utilise all their oxygen, but at the same time, if these patients do not move and take big breaths and cough, then they're not going to get better. So our physios are often seen trotting hypoxemic patients up and down the corridor, and it really does seem uncomfortable, but these patients, they need to cough. They need to take nice big breaths and open up that consolidated lung.
They have nasal prong with the oxygen bottle, by the way, just they're not just...
Not always, it depends how bad they are, but yeah, generally we'll supplement oxygen.
We're not making them hypoxemic. So then we're just going to go through some points to really emphasize from this lecture, some like take-home messages. Do you want to do
Yes, I can do these. Yeah, so yeah, information is very easy and quick to gather if you know how. So thorough assessment, examination, blood work and POCUS, ultrasound, I think we'll all keep pushing that as a concept. I think ultrasound can be really, really useful to just find out more about your patient early on. Attention to detail when stabilising emergency patients, obviously very important as well, and then they can hide a lot of issues, especially with our polytrauma patients. They can be a lot more complicated than we expect on first assessment. Crystalloids aren't always the only and best option. Obviously they're where we generally reach first, but you do have other options available as well, and especially in terms of plasma and blood products. Analgesia should be considered part of your initial stabilisation, but then reassessed all the way throughout. Really, really important. Selecting which patients require perioperative antibiotics, obviously very important. We've obviously got a huge shift towards using less antibiotics wherever we can. NSAIDs aren't always appropriate. They're great when they're great. So yeah, for those patients that are stable and due to go home, absolutely perfect. If they've been recovering for 48 hours and there's no sign of an AKI, brilliant. But generally with these trauma cases that are likely to get a lot worse before they get better, definitely avoiding, and certainly in the acute phase for our other patients that we discussed as well, definitely going to be avoiding those. Considering all the different options that we have for multimodal analgesia, hopefully if you're not already using paracetamol, you can start incorporating that into your daily practice. Lidocaine, obviously all the other infusions that you can use the VASG.org website for. Co-induction, can I achieve the same without pre-medication or sedative drugs? So these combinations, when we induce patients, really, really quick, smooth inductions requiring very few sedative drugs. Not every patient requires intravascular fluid therapy post-operatively. It's very, very easy for patients to become fluid overloaded, even on 2 or 3 ml per kilo per hour if we're leaving them on them for a very long period of time. So just continually reassess and really think, do my patients really need this fluid? Post-op nutrition, very important. Obviously, we've talked about feeding tubes as we go through. These patients are not going to recover if they don't get nutrition, if they can't sleep. Every hospital should have some nighttime hours for these patients to be able to sleep. I think I may even have a slide on this later on, but yeah, do your patients need to have their medications dotted throughout the night? Can they have them at a specific time point? Do they need to be woken up for those medications? Could they just be bumped by an hour or 2 hours till the morning? If it's an intravenous drug, can it be given through a fluid line? So things like the post-op nutrition and then managing these patients holistically is very, very important. Assessing for and treating post-op nausea has a big impact on our patients. Certainly thinking back to our GDV, a lot of the time when we palpate our patients in the cranial abdomen, they respond and then we analgese them and then they're just more nauseous. And a lot of the time, actually, they're just nauseous in the first place. So taking that time, instead of just pushing really firmly on the abdomen, really spend a bit of time feeling around, not even putting a huge amount of pressure, just get them really comfortable with what you're feeling and that you're just there. Because they'll often relax after a period of time and then just really slowly increasing your pressure. And sometimes in some dogs you'll get your fingers all the way together across the abdomen. Not suggesting that on big dogs, but certainly you can tell whether these patients are nauseous or painful because they often won't respond significantly with quite firm palpation. But then as soon as you stop, they're there and they still look miserable and they're still lip smacking, etc. And then you might want to consider anti-nausea medication. So yeah, I already talked about the sleep bit, I just couldn't wait. But yeah, it's really, really important to consider this for our post-op patients. They've got so much to recover from, and I think we keep these patients awake for a lot of their time in hospital. So giving them a nice experience and the ability to heal is really important. So we've got a QR code here, so if you want to scan that, then you can get a PDF of the slides. And then if you have any questions, we would be very, very happy to have them.